The glenohumeral joint is composed of the humerus and scapula and is the most mobile joint in the body. The motion of the humerus relative to the articular surface of the scapula, the glenoid, is described as spinning, sliding, and rolling. Shoulder motion and stability is achieved via the coordinated contraction of the deltoid and rotator cuff. The deltoid is the largest muscle in the shoulder. It elevates the arm. The deltoid consists of 3 distinct heads: anterior, middle, and the posterior. The middle deltoid wraps around the greater tuberosity to generate a stabilizing compressive force. The rotator cuff is composed of 4 muscles that generate the torque necessary for rotation. The anatomic arrangement of these muscles generates humeral head compression and glenoid centering at all joint positions. Muscles generate forces that are converted to torques in proportion to the perpendicular distance between the joint center of rotation and the muscle's line of action. This distance is the muscle's moment arm. The larger the moment arm, the greater capacity for that muscle to generate the torque required for motion and support external loads. The location of the moment arm relative to the center of rotation determines the type of motion the muscle creates. Shoulder muscles with lines of action superior lateral to the center of rotation generate abduction. Lines of action inferior medial to the center of rotation generate adduction. Lines of action anterior to the center of rotation generate internal rotation. And lines of action posterior to the center of rotation generate external rotation. Rotator cuff tears have negative consequences on motion and stability. As the rotator cuff fails to balance the deltoid, the humeral head migrates superiorly and impinges with the acromion, leading to further tearing. Dr. Charles Neer coined the term cuff tear arthropathy, or CTA, to describe this arthritic, eroded condition of the glenohumeral joint following prolonged subacromial compression. The standard of care for CTA is reverse shoulder arthroplasty. The reverse shoulder prosthesis inverts the anatomic articulation, making the glenoid convex and the humerus concave. Inverting the concavities restores stability by creating a fixed fulcrum that prevents superior migration, facilitates the deltoid to elevate the arm, and limits motion to only spinning. Inverting the concavities also causes an inferior medial shift in the center of rotation and position of the humerus. This dramatically alters the relationship of each muscle relative to its normal physiologic function. Medially shifting the center of rotation increases the length of the deltoid abduction moment arms, improving its efficiency to elevate the arm. However, medially shifting the humerus shortens the rotator cuff muscles, which has negative consequences on rotational strength and motion, and leads to impingement of the humerus with a scapular neck, known as scapular notching. Inferiorly shifting the center of rotation and humerus elongates the deltoid. Deltoid elongation improves muscle tone and has been suggested to increase strength and joint stability. However, deltoid elongation modifies the normal contour, decreases wrapping around the greater tuberosity, and creates cosmetic concerns. Excessive deltoid elongation may lead to acromial stress fractures. Inferiorly shifting the humerus alters the subscapularis and infraspinatus line of action, increasing their adduction capability at low elevations, counteracting the work of the deltoid. Different prosthesis design parameters impact how the center of rotation and position of the humerus change relative to the anatomic shoulder. The Grammont reverse shoulder glenosphere, whose thickness is 1/2 its diameter, medializes the center of rotation to the face of the glenoid to minimize the torque on the glenoid bone implant interface and increase the deltoid abductor moment arm lengths. The Grammont humeral prosthesis has a 155-degree humeral neck angle and is placed within the humerus, causing it to shift medially and be placed directly inferior to the glenosphere, which elongates the deltoid but shortens the rotator cuff. This implant design and resulting humeral positioning is effective at restoring active abduction and forward flexion, but is less effective at restoring active rotation. Grammont's medial positioning is also responsible for a low glenoid loosening rate, but a high scapular notching rate. Prosthesis designs that lateralize the center of rotation relative to the Grammont may improve active rotation, strength, and stability, and also reduce the scapular notching rate. Lateralizing the center of rotation lateralizes the humerus, which tensions the remaining rotator cuff muscles and minimizes humeral impingement with the scapular neck. However, lateralizing the center of rotation increases the torque on the glenoid fixation surface and decreases the length of the deltoid abductor moment arms. Because the deltoid moment arms are decreased as the center of rotation is lateralized, the deltoid becomes less efficient and requires a greater force to elevate the arm. These elevated loads have negative implications on rehabilitation, muscle fatigue, stress fractures, and prosthesis fixation. Alternative prosthesis designs are available that lateralize the humerus without lateralizing the center of rotation. Doing so better restores rotator cuff muscle tension while maintaining Grammont's deltoid moment arm lengths and minimizing the torque on the glenoid implant bone interface. The humerus can be lateralized to also minimize scapular notching by decreasing the Grammont humeral neck angle of 155 degrees, proportionally increasing the Grammont glenosphere diameter and thickness of 36 by 18 millimeters, decreasing the humeral liner constraint, and by increasing the medial offset of the humeral prosthesis. Increasing the humeral liner stem offset increases the deltoid abductor moment arm lengths to improve joint efficiency and increases deltoid wrapping to improve stability. Next-generation implant systems achieve this increased offset by placing the liner on top of the resected surface instead of within the humerus. Doing so permits the same humeral stem for both anatomic and reverse shoulder arthroplasty, improving the ease of revisions and reducing the overall cost by retaining the same implant. Repair of the subscapularis with anatomic shoulder arthroplasty is critical. Restoring the transverse force couple created by the subscapularis and posterior rotator cuff is essential for stability. However, the combined force generated by these opposing muscles increases the joint reaction force. With reverse shoulder arthroplasty, as the subscapularis functions as an adductor, its line of action opposes the deltoid, requiring the deltoid to work more for a given motion when the subscapularis is repaired. However, subscapularis repair may not be necessary for stability for alternative prosthesis designs that lateralize the humerus more. Thus, recommendations for subscapularis repair are not universally applicable to all reverse shoulder designs. The requirement for repair is dependent upon humeral positioning. Not repairing the subscapularis with lateralized humeral designs may reduce the force required by the deltoid and reduce the overall joint reaction force, since the subscapularis no longer functions as an adductor. Glenoid implant positioning alters reverse shoulder biomechanics. Inferior glenoid placement is recommended to achieve glenosphere overhang and avoid scapular notching. However, inferior glenoid placement further shifts the center of rotation and position of the humerus. This further elongates the deltoid, reduces deltoid wrapping, and may also increase the risk of acromial stress fractures. Using reverse shoulders in eroded glenoids medializes the joint line, further shortens the rotator cuff, and further reduces deltoid wrapping. Excessive joint medialization can completely eliminate deltoid wrapping and cause the deltoid to generate a distraction force. When using reverse shoulders in eroded glenoids, the joint line should be lateralized to improve stability using thicker glenospheres, bone graft behind the base plate, augmented glenoid base plates, or a combination of each. The optimal method of treatment may vary depending upon the type of glenoid wear pattern. Multiple augmented base plate options are available to treat each of the different wear patterns commonly found with reverse shoulder arthroplasty. If the glenoid wear pattern alters the native glenoid version or inclination, eccentric reaming may be necessary to realign the joint. Unfortunately, eccentric reaming removes additional bone, potentially compromising glenoid fixation while further medializing the joint line. Augmented glenoids realign the joint with off-axis reaming, which removes less cortical and cancellous bone than eccentric reaming. By conserving more glenoid bone, the anatomic joint line is better maintained, thereby providing more anatomic deltoid wrapping and more anatomic rotator cuff tensioning than occurs with eccentric reaming. The joint line can be lateralized without eccentric reaming by using bone graft behind the base plate or augmented glenoid implants. Augmented glenoids offer a simpler, faster, and more cost-effective method to lateralize the joint line since they don't require harvest of autograft or purchase of allograft, both of which must then be sculpted to fit the deformity. Furthermore, base plates with bone graft have a greater risk of loosening since they have poorer initial fixation and are also susceptible to graft resorption. Posterior glenoid wear is common in patients requiring anatomic or reverse total shoulder arthroplasty. Posterior augmented glenoids are available for both applications and in various augment sizes to address different amounts of wear. Posterior augmented glenoids are implanted with off-axis reaming to correct glenoid version while preserving anterior glenoid bone using either a 2 mm K-wire cannulated or free-handed technique. Cannulated technique. Insert 0° K-wire along the native glenoid axis. Insert 8° K-wire through alignment guide. Remove 0° K-wire and guide. And ream off-axis. Reinsert the 0° K-wire and guide. Then remove 8° K-wire and guide. And drill the center hole through the drill guide. For anatomic total shoulder arthroplasty, drill peripheral holes through the drill guide and insert cement into the holes. Next, impact posterior augment components. For reverse total shoulder arthroplasty, insert compression screws and locking caps into the base plate. Then insert glenosphere and locking screw. Freehand technique. Alternatively, if the surgeon prefers to ream off-axis without the use of K-wires, guides are provided to assist with the freehand technique. These clear sizers are shaped like each size implant to verify bony support. When using reverse shoulders in superiorly worn glenoids, the joint line should be lateralized with superior augmented implants. When using reverse shoulders in superiorly and posteriorly worn glenoids, the joint line should be lateralized with superior posterior augmented base plates. These devices are implanted using the same aforementioned surgical steps to implant the other augmented base plates.